And then the second relevant area with respect to the ankle specifically would be the midfoot. And so the midfoot is a little bit more tricky from an anatomy perspective, but we'll specifically talk about the medial part of the midfoot. Oh, there we go.
All right, so go over that anatomy one more time. I'll see if I can figure out how to use this program, which likely I will not be able to. Here we go. So there we have that space that Mike is referring to, the mortise joint itself. This is the talus, and then you have this tibia and fibula sitting there. And then as I come around that way, you see the talus sitting on the calcaneus, and that calcaneus is forming the subtalar joint,
which you see right there. Yep.
I should be able to. Wow, I was the smartest person. This would be a lot easier. Then you have the calcaneus. There you have that subtalar joint in there, and there you have that mortise. So go ahead, Mike. This is from behind.
Well, so this is actually a really good picture. So you can see how the talus kind of sits on top of that calcaneus there. Can you flip that back to the medial side? Yeah, perfect, right there. You can see how the talus sits on top of the calcaneus. And so that's the back side of the talus. So that should help us understand, oh, that's even better. That should, so you can see kind of right there, yes, exactly, you just read my mind. Right there, the only way for that area to move would be in rotational type motions, right? Because if you tried to make that subtalar joint a purely linear motion, you would actually just ram the talus right into the calcaneus. But because the foot needs what we call a triplanar motion to be able to adapt to the ground and adapt to whatever surface or environment you are in, that talus has to move relative to the calcaneus, and it only can do that when it slides or it rotates over top of the calcaneus, which allows us to get what we call subtalar motion. And subtalar motion, that rotation of the talus on the calcaneus leads to what we call subtalar inversion or eversion.
And I mean, if we put it this way, and so now we're looking straight on the foot, you can see that the rotation that would occur between this and this is going to cause a caving on this side or a caving on that side.
Correct.
A caving on that side is what we refer to as pronation, and a caving out to that side, we refer to it as supination. But as you can see, what happens here is also going to be somewhat determined or determinant by what happens between these bones as well. So you have a situation where what's happening here is going to be dependent on here. So let me just stop for 1 second. So in FRC terms, we say that you require tilting, right? And what we mean by that with rotation before linear, if you want dorsiflexion, if you don't allow this unit to tilt in or to tilt out, you just won't be able to get the dorsiflexion you want. And further, if this midfoot is stiff and it's locked into more of a supinated position, so let's say this is really high, you get no drop of this midfoot, you get no drop of this in pronation. If it's always locked in supination, then you're going to get more problems clearing that talus as you dorsiflex. You're going to start to get impingements in here. And that's why a lot of the times the ankle dorsiflexion limitation is not because of muscles in the back, it's because of what's happening here in the front.
Yeah, 100%. If you actually flip it around to the back again, if you don't mind, what you did there was actually really kind of cool, because you traced out what you call tilting. So you tilt it to the inside and you tilt it to the outside. And really what you're tracing out there is you're tracing out that upper part of the rotation of the ankle. You know what I mean? You're tracing out the dorsiflexion part of ankle cars, which is really just tilting.
100%. So now, Mike, do you want to? Another thing that you could do, guys, and I wonder if I can. Let me see if I can just. This
is a pretty wild program.
This is the one that we're using for the seminars from now on.
Yeah.
So if we look at it from the top now, guys, the thing that I like to do is if you just keep the person, you're staring at the person's foot, they're standing, the rules are they have to keep their big toe down, okay? So no matter what happens, they have to take their big toe and keep it down. down where they are, and all the other toes have to hit the ground. You should be able to really flatten the inside arch, and then you should be able to roll up into supination while that big foot stays down, or that big toe stays down. And while you're doing that, what you should be seeing is actually rotation through this ankle. Does this make sense, what I'm saying?
Yep.
So in other words, when you drop into inversion and you flatten out this arch here, so you get a dropping of the metatarsal head, you get inverting of this tissue coming down towards the floor, you'll actually get a rotation. Can you see my cursor too, Mike? Is that a...
Yeah, you can. Yeah.
Okay.
Yep.
So you'll get rotation through this mid part of the foot down towards the floor. All of this will rotate counter to what that rotation's occurring. And then when you go into supination, this will rotate backwards, and then this will come up as you evert. It's a hard thing to explain, but with your toe down, you should be able to tilt in and out and see the amount of rotation that you see. And if you don't see a lot of rotation in there, the idea that you're going to then go ahead and work dorsiflexion is futile. That needs to happen before dorsiflexion can happen. That's why we're saying rotation first. Open up your tilt, and then once your tilt is open, then you can start opening up your dorsi or plantar.
Yeah. Can you put that anatomy picture back up just so people have an understanding of what we're talking about?
Sure thing.
So go back to that top view. You know when you were kind of looking straight down the shank, right on top of the foot?
Oh, no, I know what you want. I just don't know how to give it to you.
Yeah, that's close enough if you just slide it into the middle.
There we go.
So just so I'm trying to talk to you through the screen here, just throw your cursor right on the navicular. Good. So if we're talking about the midfoot, just so everybody is on the same page here, the middle part or the medial side of the midfoot is your navicular. Your navicular is going to be attaching to your calcaneus. That is the first part of your midfoot. So you can see calcaneus, we just talked about the talus, and so your navicular is going to articulate with the calcaneus as well as the talus, okay? So when we talk about that tilting that Dre was just talking about and that rotation of the midfoot, that's why that rotation has to happen. That navicular has to get out of the way either in an inversion motion, which we'll call pronation, or an eversion motion, which we can call supination, to allow for normal ankle mechanics to occur. If we take that a step further, one bone down will be the medial cuneiform, which is also part of the medial side of the foot, not necessarily part of the midfoot. We'll talk a little bit more about the cuneiform next, because we're going to talk a little bit about the big toe and the importance of the big toe, because there was a question about that. But the cuneiform also attaches to the navicular, and so there's going to be relative motion between the cuneiform and the navicular as well, and that motion is also going to be rotational. So you can see that if your foot is going to adapt to the environment, your foot is going to adapt with rotation. And as a result of your foot adapting with rotation, your ankle also has to adapt with rotation as well.
So I guess, do you want to go into that big toe right now, and then I'll go to that video so we can talk about strategies as to how to invert evert?
Yeah, we might as well, because the anatomy's up. So the question that we had, if I summarize it, because we did have a couple things about the big toe as well. So to carry on from the foot and ankle, how do we adequately assess the big toe? So we do assess big toe dorsiflexion as the standard operating procedure at the FRA. So we talk about how we do the table test for the big toe. We also have foot intrinsic stuff that we do from a CARS assessment perspective. So the questions, again, I'm kind of summarizing them. A, what is the mechanics of the big toe? So we can kind of talk a little bit about that. And then considering that the first metatarsal, so we'll talk about the first metatarsal, will drop when we assess dorsiflexion, how much is too much? And what can we deem to be compensatory motion of the foot when we assess the big toe? So this is a perfect view to kind of talk about this. So if you don't mind just kind of putting your cursor right at the joint of the big toe where it's going to dorsiflex. So there's the joint between the metatarsal and the first phalanx. That's where your big toe is actually going to dorsiflex from. So just to review from standard operating procedure of the FRA, we take this, we grab the phalanx of the big toe and we pull it passively into dorsiflexion, okay? We're in a weight-bearing position during this test, just to mimic what we would be like when we are using our big toe anyway. So we pull the big toe into passive dorsiflexion. Now, for that passive dorsiflexion of the big toe to happen, if you look at the big bone here, that's going to be your first metatarsal. And your first metatarsal will start to drop to the ground. So if you can kind of imagine that there would be a flat surface under this foot, the metatarsal will drop to the ground, which we call first metatarsal plantar flexion. So it will drop to the ground, which actually allows for the phalanx to glide on the first metatarsal to move that big toe into dorsiflexion. So when we assess for big toe dorsiflexion in the FRA table tests, we are allowing for that first metatarsal to plantar flex. And it will plantar flex all the way to the ground. So there is no compensatory motion, or there is no too much motion of the first metatarsal, because at some point in time, if it plantar flexes, it's going to hit the ground. And when it hits the ground, technically you will run out of big toe dorsiflexion, okay? So when we're talking about compensatory motions when we assess the big toe, the main compensatory motion that we're going to get is back up at that medial cuneiform, okay? Which is why, if you guys remember, for those of you who have taken FRA, what we do when we assess the big toe is, if we're looking at this picture that Dre has up on the screen now, if you imagine that I have one hand pulling up on the big toe into passive dorsiflexion, so let's say I'm looking at the foot like this, face on, my left hand would be pulling the big toe into dorsiflexion. My right hand, I would slide under the arch right at that joint between the first metatarsal and the medial cuneiform. What I don't want to have happen when I assess the big toe is that for that cuneiform to drop towards the ground, because that will be, if I'm pulling up on the big toe, we have to remember that I'm also going to be tensioning the plantar fascia. Because I'm tensioning the plantar fascia, technically the arch should not drop. And if that cuneiform moves towards the ground or rotates inward, technically that means that the arch is dropping. And we do not want the arch to drop when the big toe is going into dorsiflexion. So what you'll feel is you'll feel the cuneiform come right into your hand, and we can deem that compensatory motion. So when then on the FRA, if you feel that cuneiform drop, you will stop your assessment of big toe dorsiflexion, because that would be deemed a compensatory motion. Does that make sense?
Makes sense to me, and we have no way of asking people, so let's just assume that everyone fully understands that now. Yeah, no, that makes perfect sense to me. Do we need this back up right now, or do you want to?
No, I think we can go to that video, because that will help us answer the second half of all of this foot and ankle stuff, which is, what is the best way to try to improve inversion eversion?
So you know what? I'm going to keep this anatomy up for just one more second, because I want you guys to understand once again what we're trying to do here. We need to make the entire unit have more space to work with. We need to increase this workspace. So to increase this workspace, you cannot just ram the foot into dorsiflexion or plantar flexion. You need to have some degree of give in all of these tissues so that you can have some tilt of that midfoot, allowance of tilt, the tilt in the subtalar, tilt in the mortise, tilt in the midfoot. All of those things have to occur this way before you can get that and you can get that. So when we talk about pails and rails, we're really talking about accessing this tissue here, and we're talking about accessing the tissue out here in order to allow this calcaneus to tilt. So just think I'm grabbing the calcaneus head on, it's got to go that way, and it's got to go that way. So let's go ahead and Let me see. I'll stop share for a second, and then I'll share it back.